I'm Bob Valente. I'm one of the rheumatologists here at the Arthritis Center of Nebraska. Some of you guys know me, some of you don't. If you can't hear me back there, there are a bunch of chairs up here, just to let you know. But then you may get picked out of the audience to demonstrate, so just let you know. Today we're going to talk about something called trochanteric area pain. And this is pain on the outside of the hips. The hip joints are in here on the outside of the hips. How many of you have trochanteric area pain? So you're going to find out you're not alone here just in this group. You're going to find that a lot of folks have this problem. We're going to talk about it today. If I can get, there it is. So we're going to talk about what it is. We're going to talk about what conditions are associated with greater trochanteric area pain syndrome, and we're going to talk about what you can do about it. It has lots of different names, so you may not have heard greater trochanteric area pain syndrome or GATSP or whatever from your doctor or from your therapist or from your nurse practitioner. They may have called it trochanteric bursitis or trochanteric syndrome or trochanteric tendinitis or rotator cuff of the hip. I had a patient today tell me she was told she had iliotibial band syndrome, which is very similar to this, only slightly different, but it usually includes this problem. So it has lots of different names, but it all has the same symptoms, and that's an aching pain on the outside of the hip, tenderness over the bump right here that you can feel where your hip bone is, and it gets a lot worse if you lift up that leg and somebody was to push down on it. That muscle that holds up that leg would cause a lot of pain right there. When we move internally and externally with the hip, it doesn't hurt unless you bend the knee. So if you bring the knee up and then do that, then you feel it. And that's because you're putting those muscles on a stretch. And one of the other criteria for diagnosis is if you inject this area and it gets better, even temporarily, this is a good sign that it's related to this problem of greater trochanteric area pain. So about 10 to 20% of all adults over the age of 60 have this problem. You really are not alone. It doesn't occur that often in primary care visits, but I suspect that's just because people don't look for it. About a third of the people who come to see me in my clinic for some arthritis concern also have this. This is not arthritis. It's more commonly in women, a little more common in folks that are overweight because they have a wider carrying angle. So do women. Their hips are wider than their stance, and that increases the risk of this, in my opinion. They have frequently low back pain, LBP, 35% of them, and many had been previously looked at with MRIs and neurologic evaluations and orthopedic spine surgeons because they thought the symptoms were a pinched nerve. This can be associated with pain that's referred to the knee, and it can be a part of the syndrome of I hurt all over and I'm tired, or fibromyalgia. But there's a wide age range. It's not just people over age 60. But as you focus on people who have symptoms that just never go away, you see that that increases with age. The Mayo Clinic study in 1996 done by a friend of mine, Mohammed Shabib, found that about the average age was 66 in their study. So they were mostly female and 82% female, and they really felt the wide carrying angle was a risk factor, but it's not the only reason that the people get this. Interesting thing is that when I was at Mayo, I used to teach the residents, and I had a resident from Thailand, and we were doing the injection clinic, and we were injecting trochanteric areas here, and I said, do you have to do this in Thailand? And he says, no, we never see it in Thailand. Never see it in Thailand. It's really interesting, and we're going to talk a little bit about why that might be in just a minute. But this affects quality of life. We think about arthritis being a problem, and I've seen several people today, for instance, where their hip is worn out and they can't get out of a chair, they can't get out of their car, they can't bend forward and tie their shoe. The pain is there all the time. It's a very bad thing. And here, if we took an x-ray of a person who has trochanteric area pain, the x-ray of the hip is normal much of the time. And yet, it turns out there's no difference between having advanced osteoarthritis of the hip and having greater trochanteric area pain with regards to quality of life, disability, and so folks are miserable with this problem, as you who have it can attest. Well, why is it a Western affliction? I think it's because in most parts of the world there are no park benches. There are no toilet. If you've been to a place like this, you realize there's no toilets. That's really frustrating, you know. And so they have to squat wherever they go. Well, it's interesting that squatting is an age-old thing where your feet are flat on the ground and you squat, and you can do this for hours, but we can't. In fact, they looked at 100 Australian women that were having problems with urinary incontinence. And the theory is because they have weaker pelvic musculature, they have urinary incontinence. This was the theory. And so 1/3 of those women couldn't even sit in a squat for 30 seconds before they fell over. So the thought might be is we all need to start squatting. Like that. In fact, there's a guy on the internet that sells one of those platforms, so you can go right back to the Stone Age and use your toilet and keep doing that. I don't think that's the answer. But I do think that we do have to work on those pelvic muscles to make a difference here. And when we look at greater trochanteric area pain, this is the anatomy, and this is the big hip bone. There's the ball right there where the joint is. This is a long ways from that, essentially, because that's in the groin here, and this was what we're talking about on the outside. We have a series of muscles that come around and attach to this bump. And between the muscles, there are bursae. And so that's why people have concerned themselves with this being a bursitis. There's the deep trochanteric bursa right there. There's a superficial bursa over the top of it. Bursa are little fluid-filled sacs that allow the muscles and the skin to go over bumps without getting caught. That's what a bursa is. And yet it turns out, and that ain't going to work, but we can go to that one right here, right next door. There we go. It turns out that the bursae aren't going to be the big deal here, even though people have always called this trochanteric bursitis, and we'll explain that. The more important things are this long, skinny muscle called the tensor fasciolata, or the iliotibial band, and that can rub over the top of that bone. But the most important ones are the muscles here, the gluteus medius and the gluteus minimus, that attach to that part of the bone. And what that does is that, here's a big one right here, that gluteus medius. What that allows you to do is when you stand on one leg, your hip doesn't fall down, your pelvis doesn't tilt, because this muscle holds that there. Otherwise, it's just a hinge, right, and you'd fall over. So you have to have these muscles strong, and that's going to turn out to be important. So in the old days, direct trauma, a hit here, could cause trouble with this problem. And actually, that's how mine started 15 years ago, playing tag football on wet grass. And I slipped and landed right on this, and it's been hurting ever since. But micro trauma is probably more common for the folks who've had it for many years than when it started in their 50s and 60s. And that micro trauma can occur just with everyday use, particularly if these muscles are weak. You actually are giving little shocks to these muscles every time you take a step. There's the snapping hip and the impingement, which may cause a problem with some folks. You can get calcifications in this area for two reasons. One, the tendons are degenerating. The others, you've had multiple injections. And you can get a tendinitis from overuse. But in any case, many times we don't know what it is. For me, I know it is in me, but I don't know what it is in everybody. It's just there. The pain doesn't stick right there over the hip, though. It can radiate into the buttock, into the groin, down the leg. In fact, it can go usually down to the level of the knee. And people might say, I have sciatica, but sciatica never goes down the outside of the leg to the knee. Sciatica has to turn and come across the front of the knee, because that's the way the nerves work. So when you have a pain that goes straight down the leg and doesn't follow the usual nerve pattern, then that's a kind of a pseudo-sciatica. But many people will complain of this, and occasionally it can even go below the level of the knee. And that will really get confusing, and there's several reasons for that, because this occasionally can be seen with a nerve pinch as well. It gets worse when you sit for a long time listening to people talk. Or if you're having to sit in a car. If you have to stand for long periods of time at the post office, it'll happen. You're actually better off walking on flat ground. If you have to lay on that hip at night, it can be quite painful. And if you have to go up and down stairs, remember we said that pain is made worse when you bring that hip up and turn it in and out. What you're doing is you're putting those muscles on a stretch right over that irritated area. And then even crossing one leg over the other, so avoiding the tight French cross, which is what women like to do and sit with a French cross and cross their legs tightly, that can irritate that as well. And as we said, we find that there's tenderness and it's really focal right over that bump, but then it may extend down that iliotibial band. And when the person lifts their legs up like that and I push down, the pain is referred right back to that spot right there. And when you don't have that, that is a sign that there may be something wrong with the hip inside, not just on the muscle at the hip bone. And this is where we flex the knee here and show that when you flex the knee and then bring it up, that'll cause pain, whereas I can take and rotate the hip back and forth with the person having their leg lay on the bed and it doesn't hurt. So the ball and socket's fine, but when I get that and bend the knee and then start going back and forth, I'm putting all those muscles on a stretch because I bent the knee, and that adds a little stretch to it. One of the more important tests is when a person lays on their side and their knee here was touching the other knee. You pull it over and see if it touches the ground. That's called an Ober test, and it's a negative Ober test if your hip can touch the ground. But I see a fair number of people with hip pain where when you let go of this, it doesn't fall down, it goes up, because they've developed a contracture of that muscle. And if you don't fix the contracture of the muscle, you'll never make the pain in your hip better. That's a positive Ober. Ober was some guy. I don't know who he was. Okay. But one of the better tests is if you're having someone I hold on to their hands and then I ask them to stand on one leg. And if the pelvis falls or they have poor balance, and a lot of times they go, I have poor balance. Really what they have is weakness of this muscle. And so the hip joint is just a hinge there that's falling over because they don't have the strength to hold it up. That's called a Trendelenburg sign. And when I see that, that means there's serious pathology of that muscle, that gluteus medius muscle that holds us up. Sometimes when people walk, that muscle is weak enough so that when they're walking, they can't, if they put their leg down like this and they stand and they're moving this leg to go to the next step, right? When they're doing that, they're so weak that the hip actually collapses, and so they would fall over. So what they do is they put their weight over the hip so that they've changed their center of gravity. So when they have this weakness, they'll walk like this. Now, if your hip hurts because you have osteoarthritis in your hip, you'll walk like this. You won't put as much weight on it. So there's a big difference in the gait. That gait is called a Trendelenburg gait. Again, Trendelenburg was some guy. You would think that he's pretty famous for just making that kind of a notification, isn't he? Okay, when you take an X-ray of a person who has this problem, okay, you will see in a small group of people calcification, and this is a little bright so you can't, calcifications, little wispy calcifications, sometimes right along here. And this is calcification in the tendon and the muscle that's attaching to this bone. Most of the time, you'll see a pretty normal hip, but in about 20% or so, you may see some hip osteoarthritis. People talk about the wider carrying angle a little bit, but there's no way you're going to be able to diagnose it on an X-ray by saying just they have a wider carrying angle. Now, this calcification in the tendons is like having a rotator cuff problem in your shoulder with calcifications. But one exception, when you continue to repeatedly inject to this area, the tissues will all become damaged. And when they get damaged, they'll form more calcifications. So you actually intensify the problem with repeated injections here, to the point where those calcifications are very, very prominent. When I first moved to this clinic 16 years ago, I inherited a lot of older women that had been getting injections for years. And they all had terrible calcifications here. And they also had a situation where you couldn't make them better with injections anymore. It just didn't work so well.
So what do you do?
We're going to talk about that. I don't do anything because I can't. They're cripples, unfortunately. There isn't just, you just don't keep getting injections. When you take and do a bone scan, this lights up where there's damage to bone. When you have trochanteric pain, it lights up right where that bone muscle attaches to bone. The hip's okay, but the bright spot, that dark bright spot right there, that's the inflammation right at the muscle attachment to bone. And when you do an MRI, the hip looks normal here, but the gluteus medius tendon that attaches here is inflamed, so it's real white because it contains a lot of water. You can see the right side is normal. And also the muscle gets replaced with fat because it's not being used right, it atrophies. And when muscle atrophies, it gets replaced with fat. When muscle is replaced with fat, it's weak. Okay? So that all is how it looks. Now, occasionally, that will be torn. And when you have a positive Trendelenburg sign, it's a bigger risk that that is torn right there. And a torn tendon is a very big problem. And repairing that isn't necessarily a solution to making it better, although that would be an option. So the MRI has been helpful for this, but I mean, you can figure this out 99% of the time with what I've been telling you about with the exam. So they looked at 250 people with trochanteric bursitis, trochanteric area pain, and did MRI. 14% had either tendinitis or a tear of that tendon. And only 14, that's 5.6%, had a bursitis. So only 5% really have bursitis. 95% will have a tendinopathy like a tear or just tendinitis. And almost always, if you see atrophy and fatty replacement, there's a component of tendinitis. Now, we don't know how often this is seen in just normal people, but it's tough to get a study where they just do a bunch of MRIs on normal people. So we think that that's pretty significant. And it's really then very rarely bursitis, even though everyone calls it that. So they took 24 people who had this problem, and they weren't getting better with a program of physical therapy, and we'll talk about that in just a minute. They were all women, age 58, so a little younger than the average for the Mayo study, and they had symptoms for 12 months or longer. And when they did the MRI, 46% had a gluteus medius muscle tear, and most all the rest of them had tendinitis. 8%, the other study was 5%, 8% had bursitis, and 1 had bad hip. They really had a bad hip, and that was missed. So again, most of the time it's a tendon problem, a muscle attachment to bone. Other things can be mistaken for this trochanteric pain. It can be an inflammation of the hip joint, although we're real good at figuring out those differences on examination. There can be referred pain from osteoarthritis of the hip to the trochanter, or even from osteoarthritis of the knee back up to the hip. You can have referred pain from the low back, particularly the degenerative changes that can occur in the back from L2 to L4. You can have just a mechanical back pain, but I'm not convinced that that's really referred to this area. A lot of times when people come to see me, their ankles cave in and they have flat feet. And that can create an environment that this leg is slightly shorter than the other leg. And that is enough of a mechanical difference that I see a lot more trochanter pain on the side where the ankle caves in, and what we call posterior tibial tendon dysfunction. If you have a pinched nerve from before, let's say you had a sciatica, if you guys have had one, L4 or L5, those nerves that come from the back feed the muscle that works this. So you may have had a pinched nerve, you got over the pinched nerve, but it left a permanent loss of nerve function to that muscle. So that muscle stays a little weak. So when it's weak, it's going to set off this problem of trochanteric area pain in many people. And then finally, some of the hip arthroplasty surgeries actually take that piece of bone off, and then they stick it back on again, but it doesn't always work so well the second time around. So that can be a problem after a hip replacement. And if you look at people who are being seen in spine clinic for back pain, they found that 20% of the people who were referred for back pain really had this greater trochanteric area pain as their main concern. It wasn't back pain. It was trochanteric area pain. But of that group, already half had had an MRI of the spine because people didn't take the time to do the examination to see where they hurt. And actually, in that group with the severe pain here, of them, 15% had evidence of a previous nerve injury down their leg, so it made it weak. It wasn't, the nerve injury was no longer causing the problem, but it made it weak. And it turns out that several patients had even gone on to have surgery for back pain when the problem was really their hips. I've seen that quite a lot, actually. So when we see someone who presents with maybe this trochanteric pain, but it doesn't respond to injection, it doesn't respond to conservative therapy, I start thinking, is it referred pain from the back or is it referred pain from the knee? So those are good things to think about. There's a number of other things that are kind of rare. Snapping hip. It's the iliotibial band snapping hip, but that's usually pretty obvious. People who have a torn a cartilage in their hip called a labrum, that can be a problem. Uncommonly high lumbar nerve pinch, but that's almost always associated with numbness that comes around here. And there's no numbness with the trochanteric area pain. There's a burning sensation. It'll feel like a burning numbness down the outside, but when I test it with a pin, you guys can feel it just fine. That isn't a problem. Sometimes a stress fracture, but again, this wouldn't be something that's going on for 12 months. And then rarely a funny nerve that comes out of the pelvis can be pinched, called an iliohypogastric nerve. So, first of all, when you have this problem initially, if it's the first time or when you have a flare, you have to say, there's less I can do for a little bit. I have to take it easy on that hip. I got to let that tendinitis settle down. Because just if you had a tendinitis in your heel or if you had tendinitis in your arm, you know that it's rest, ice, compression, elevation. Take care of it. A lot of people want to just keep on going, however, but that's not compatible with having this get better when you have a flare. And it will flare. It'll come, you know, this tends to be a chronic illness. You want to identify the things that aggravate it. So if you walked up and down 6 flights of stairs yesterday and now you're having more trochanteric area pain, you might want to reconsider how you're walking up and down those stairs or conserve energy and figure out how you can do that less often in a day. If it was that you drove in a car all the way from North Platte to here and you did it without ever getting out of the car, well, that may be another reason you want to think about changing how you sit in a car or what you do in that car. And getting out and moving every couple of hours. Ice and heat can be very helpful for this. In fact, when it's the worst pain, ice is the best thing. Putting that right on there 3 to 5 minutes until the skin is numb. And that sometimes can get you through some of the acute flares. Managing the sleep service. If you haven't already added 3 inches of medium density temperature sensitive foam to the top of your mattress, or if you have a Sleep Number bed or a Tempur-Pedic bed, you'll find that those make a huge difference. The things that really set this off is having to sleep in a Motel 6 with one of those bricks for a mattress, you know. So you have to have that sleep surface comfortable. You don't want something firm. You want something that's supportive, that puts the pressure over a much wider area. Some people get it so bad, and a lot of those older women that were becoming hip cripples from multiple injections, and because they weren't told that they had to take care of a lot of this themselves, really end up having to use a walking stick in the opposite hand. So you unload the hip when you're walking. And that can be very helpful to reduce the stress there with a flare as well. It sounds terrible. On the other hand, when you can walk further and you're more independent, then it's a good thing. It's an independent stick, not a dependency thing. Chiropractic, physical therapy, massage therapy can always be helpful for mobilizing those muscles, because they sometimes, after you've been favoring them for a long time, the muscles will get constricted and contracted too, and you've got to get them moving. Especially the iliotibial band and the piriformis needs to be stretched. We're going to talk about foam rollers, and I brought mine because that has made the biggest difference in my pain, and so I want to share that with you all today. And then exercise, lateral leg lifts, and other ways to strengthen that gluteus medius. If you don't strengthen it, it'll never get better. Never get better. You got to do that all the time. So, next.
What about using analgesic balms or Theragesic or something like that at the spot?
You know, the question was, what about some of those really nice smelly things that you can put on a joint and make them feel better, like icy hot, deep blue, blue emu, a number of these things. And yes, just like any other musculoskeletal pain, those are called counter-irritant creams, and they are very helpful in the management of regional rheumatisms from your neck to your tailbone. They're good. So we talked about the mattress pad, cushioned insoles, So many people come in and they're wearing shoes like, and they're caving in on the inside of that. You want to keep those feet and ankles nicely aligned, even in the house. They'll tell me, oh, I've got great shoes, but they only put them on when they go out. And then they're padding around all day long in the house with bare feet. And my wife does this, drives me nuts. And so I want them to have their ankles and their feet aligned with good arch supports. And when you have osteoarthritis in the knee or hip, cushioned arch supports as well. We talked about the cane being something to be used just to get us through a flare when the flares occur, and then foam rollers. See this nice young woman here, she's on this. Now I will tell you, they make them smooth, and if I had to do it again, I'd get a smooth one. This son of a gun hurts. These are supposed to be like fingers, magic fingers. They're not magic fingers. And also, she looks really comfortable doing this. This is a really difficult thing to do the first few times you do it. Now, I got down on the ground and I look like a wet noodle over the top of that thing. But I work it, I roll up and I roll down. I do it 10 times on either side. And I found that while that was painful right here, I had more pain as I went along that condensation of muscle down along here. And that's usually not where it hurts when I sit for too long in a car. But it made a huge difference. I worked, wherever it really hurt, I would work it up and down, and I still do it 10 times each day on both sides. And then I actually do the front part, I lay on it and do that, and then I do the back part, and then I sit on it with a leg bent, and I catch the piriformis. And I've made up all kinds of things you can do with this thing. And you can't fall very far, 6 inches, right? And so it's not a big deal. And if you really feel that you can't do that, someone can do it to you, right? Right? That's kind of cool. And when you travel, you can buy a little one. And they're really kind of neat. And these rollers have become a big part of athletics because it turns out on the court, if they're injured, you'll watch them in basketball in particular. If they get an injury to their hamstring, their trainers are out there rolling it, and it makes it feel better. If you have osteoarthritis, and I've told you need to do quadricep strengthening exercises, a study showed that with that little one there, after you do the quadriceps, if it hurts, do the roller, pain goes away. So you want to use that roller. If you have this pain on the inside of your knee, below the knee joints, called Trochanteric Bursitis, you roll in that thing. Lateral epicondylitis, you're rolling that thing. You might do it with the big one up and down as you're laying on it on the ground. But those rollers really help a lot of these muscle attachment pain problems. It's not a cure, but it makes you live with it a whole lot better. I've been doing it now since the beginning of the year, and I rode 6 hours in a car that's the first time I've been able to do that without severe burning pain in that trochanter in like 15 years. So it's not the only thing that works. It's not the only thing I've tried. I still do the exercises. I do the stretches. But I've been impressed that that makes a difference. And a lot of the patients I've been selling on the idea, I don't sell these, selling on the idea of using foam rollers have come back to me and already said that does make a big difference. But not overnight. Not overnight. And it's really painful when you start it. And that's okay. It's supposed to be.
What about padding a rolling pin?
I'd for $20 I'd buy that. They're not expensive. They're everywhere too. They're at Shields. I went to the Red Dirt company this weekend to get good shoes for my wife, and they were selling them there. I bought this one on Amazon, so they're everywhere. Exercises, this is a nice one on your bed where you're stretching the piriformis muscle. This is how you stretch the iliotibial band. You stretch it this way and then go up that way. I like to hold each stretch for about 30 seconds and then repeat several times. The most important part of all this, again, though, is the strengthening of that gluteus medius. That requires a leg lift or putting your a rubber therapeutic band on the ground and attaching it to something heavy and doing a lateral sort of thing while you're hanging on. But we need to strengthen those gluteus medius muscles all the time. That's really important. And people say, I went to physical therapy, it didn't work. And I don't know what to say to that except for you've had the pain for 5 years, 10 years, whatever it is. It ain't going to get better in 2 weeks. If you chart this, it might get better in 10, 20% in 6 months, because it takes a long time to bring these muscles back. You can recall, you've seen a guy get a cast on his arm. It's only on there for 4 weeks. His arm is half the size of the other one in 4 weeks. Imagine not using those muscles correctly for even longer, years. What they're going to be looking like. They'll be filled with fat on the MRI. So in addition, what about anti-inflammatory therapy? You talked about the topical therapies. I think they're great. But if you can tolerate ibuprofen, 3 tablets 3 times a day, naproxen or Aleve, 2 tablets twice a day with food, whenever it flares, do that for a 7 to 10 day period of time. You don't need to be on it all the time. I hope you don't. But you don't need to be on all the time. But a 3-week course of it and then as needed. We want to avoid, and so many people are now taking narcotics, opiates, hydrocodone to help them sleep. And a lot of it has to do with this trochanteric area pain. That's what's keeping them up. But it's a mistake to start using the opiates to try to manage this because it takes away your understanding, your control of how to make this better. And plus, it makes you dizzy and constipated and a little silly and you can't get off the couch the next day. Topical counterirritants, I even had it on the list there. Pain rubs that you buy by prescription. If you can't take oral ibuprofen, they put the drug like ibuprofen, it's called diclofenac, also known as Voltaren. They put it in a cream and you can rub that on there. And only 4% of it is absorbed systemically, so there's little or no chance of gastric distress. And then injections. Injections are what people want first. Fix it, make me better, so I don't have to do all that other stuff that you told me I have to do. And this is a study, again, done by my friend Shabib, where they found that after 75 patients, 77% were better 1 week after injection. And if you looked at 6 months, they still said there was some residual benefit. This was their first injection. Now, patients that received the highest dose of betamethasone, that was the highest dose of steroid, did the best in that group. And similar studies, they find that people do okay with the first injection. In fact, many people will report improvement out to about 6 months or so, but many relapse. Up to a third of those or a quarter of those that have a good response will get worse again. Why? Because this is a chronic illness now. Just like having diabetes, you don't get that fixed with one insulin shot. You have to take care of it and have to manage it. I think you can repeat the injections up to 3 times in 2 years, but evidence shows no benefit beyond local anesthetic after 3 injections. So 2 hours after your injection, if it's your 5th or 6th hip injection, typically you're back to square one 2 hours after that lidocaine is worn off. And when there's no significant review of multiple injections or complications, but I can tell you I have seen them in this practice that I inherited, where many of the people ended up being crippled by their problems of trochanteric area pain, just as bad as if they had their hip was totally worn out. The difference is we can't replace this. You know, we can't. And we'll talk about surgery in a minute. We can replace a hip and people can recover. But there's also some suggestion that if you have osteoporosis and you get an injection in your dimples back here or in your trochanters, you increase the risk of a stress fracture in the next 3 months by about 1/3, just because of the extra steroid that's right next to bone like that. And there's another issue too, and that's that when you continue to inject these, you actually make things worse. Remember I told you about how the ones that had the worst calcifications around their hips were the ones that had repeated injections there. And these injection granulomas, that's what they're called, these calcium deposits will sometimes break down and start to be inflamed. We know that happens in shoulders. That's classic. It's called calcific rotator cuff tendonitis. And I think it happens in the hip as well. It's just people haven't recognized it. But after 27 years, I've seen enough of this where it can flare, and then you do an X-ray, and they've got the calcium deposits all around it. And that may be a very tough thing to treat without another injection, although that creates a problem, or oral steroids for a short period of time like you might take when you have gout. But this is an area that hasn't been explored, except for I just want to prevent people from ever getting there in the future. That's the way I feel about it. What about people using ultrasound and MRI and all this other stuff to make sure they put the needle in the right place? And it turns out the best predictor of doing well is just an unguided first injection if it made you feel better. You don't need to have an ultrasound. You can see the bursitis, and if the bursa is inflamed, injecting that will help better than a blinded injection. But remember, only about 5 to 8% of these are bursitis. The rest of them are tendinitis, tendinopathies, ruptured tendons. And then they also did fluoroscopic versus blinded injections, and the patients were randomized to having the fluoro or the blinded injection. When you bring out a big machine and you have it out all over you and there's all kinds of people around and it looks important, there's a big placebo response with that. You got to remember that. So some of that's a flourish there. But when you looked at the group, the pain scores were as good, if not better, in the one that just got a needle stuck in there without the fancy machine. So, and about 40% of them still had some satisfactory outcome, regardless of whether it was fluoro or blinded injection at 3 months. But remember, that means 60% still we're back to square one. So we don't fix it with injections. And this is a study that came out of the Netherlands. They had 60 patients that were given blind injections. 6 were just treated with physical therapy and NSAIDs. The pain got better in the first 3 months with injections, but at 12 months, everybody was right at the same place. About 60% were better with physical therapy. 60% were better with injections. So I think initially injections are helpful. I don't do them over and over again. But the outcome at the end is that if you're not doing those exercises, if you're not doing the other things we talked about, you're going to be prone to have this stuff over and over again. It's a chronic illness. What about surgery? First of all, there aren't very many people that are willing to do this surgery. I've had a number of people referred in the last 12 years, 14 years, 16 years to surgeons, and I've only had 2 of these ever had surgery. Neither one did well. Because they have different ideas of what needs to be done. Some of them released the iliotibial band. Some just tore the calcium out of there and cleaned it up. The big one right now is an arthroscopic evaluation of this area on the outside. So they do it through a small incision. They release the IT band with a cut, and they debride this area, and they remove the bursa that's in there. But again, if it's not a bursitis, this may not be the right answer, and it requires an orthopedic surgeon who does arthroscopic evaluations and management of the hip. And there aren't very many people that are trained in that, actually. Other things have been done, including cutting off the bump. That does not work. And the largest series of all of this in the entire literature is 27 patients. And you remember, 15% of all adults have this condition. So most of these people never get to surgery because this tells you so many different types of surgeries being done on so few people. We don't really know, what to cut on to fix this, and especially if the problem is just muscle weakness. Now, if there is a tendon rupture, I would think that would go to the head of the class. But interestingly, there are no large series of people just repairing that tendon. It must be incredibly difficult to do because you would have thought by now somebody would have published that. This is the gluteus medius repair, but it's almost always just after a hip replacement. They take it off and then they put it back on again. And 17 of those that had it had complications, including thrombosis of the leg, and they had a limp after they did the surgery. That's not a particularly good thing, or it retore. But most had good to excellent outcomes. Now, in an orthopedic literature, good to excellent outcome means they don't come back to see you. So, literally, he must be all right. They didn't come back. And so I have a very difficult time believing that they had a good or excellent outcome in most of these patients. So we want to maintain a healthy body weight to avoid this sort of thing. That's already kind of by the wayside for a lot of us. We want to have a regular exercise program. We want to continue to work on flexibility and strengthening of these areas right here. We want to avoid and maybe do a journal to try to determine what it is that sets these sorts of things off. We want that supportive but not firm mattress. We want to have good shoes with cushioned insoles that have arch supports so our ankles don't cave in. And we want to maintain those arches. In summary then, this is a regional rheumatism. It's not arthritis. It's easily confused with other problems, and so you do sometimes need to go through this whole differential, especially if you don't have an initial response to the injection. It can be associated with lots of other musculoskeletal illnesses, like pinched nerves, like degenerative changes in the spine. You have to have a kind of a diagnostic algorithm to work through to know what to do. And your regular primary care doctor should have this because, again, this is extremely common, but they frequently don't. And you have to realize that if you don't put yourself in the center of this treatment program, you're never going to get better. Never going to get better. And I share Reliance on injections is not just risky, but I know for a fact it will not solve the problem. In the long run, you will be a cripple if you keep getting injections. I really think those rollers make a big difference for me. I would encourage you guys to give those a try. We've gone from a situation where we were very active and always up and around to spending our whole time looking at a computer screen now. There's all kinds of complications, I think, of sitting in a chair and not squatting. Do you know that we spend 2 hours on average staring at our phones each day now? The average American, 2 hours each day. Now, some of you don't have phones, so some of the other one else has to do it 4 hours, 2 for you and 2 for... But the fact of the matter is the average is 2 hours. Just think what we had. We had all that time before. We got no time now. Anyway.